All right, hi everyone. We are going to be talking about carotid anatomy today, in addition to some stuff that's a little bit more in depth in terms of cerebrovascular circulation and supply. So we've probably seen a lot of carotids at clinical. We've maybe heard of the carotid, the ICA, the ECA, maybe the vertebral vessel before. So we're going to talk about those in depth, but we're also going to be talking about the communication of those vessels with the circle of Willis up in the brain. Now, the circle of Willis is not something that we are routinely visualizing. That is an exam that is performed using transcranial Doppler, and we don't typically do that. You may have seen Corky perform those at Rhode Island Hospital, but that's not something that is a standard exam. But it is important for us to know in terms of vascular information and the relationship of the circle of Willis with the rest of the carotid anatomy. So the cerebrovascular circulation is kind of the term that we give for the whole blood supply of the head and the neck. We break that up into different types of circulation depending on where it's going. So we have anterior circulation and then we have posterior circulation. The majority of our blood supply is going to come through our anterior circulation. It's going to feed, the front parts of our brain. It's going to feed the structures of our face. And then our posterior circulation is going to be from more towards the back of our neck, and it's going to supply the back of our brain structures. So we're going to start off with our anterior circulation, and this is some things that we've typically heard of before, probably in clinic. So this is going to be our carotid arteries. We know that we're going to have one on each side. We know that our right one comes off of the right side of brachiocephalic. The left one comes directly off the aortic arch. Both of them are going to travel all the way up the neck, and we're going to see them kind of get a little bit bulky, or what we call the carotid bulb, right when we get to that region of the jaw and the ear. So once we kind of follow that carotid all the way up the patient's neck, we see it kind of bulge out a little bit. Right after that bulge, we actually see it split, or we see it bifurcate. So that bifurcation is when the carotid becomes the ICA and the ECA. The ICA is going to be the vessel that supplies our brain, and the ECA is going to supply our face and our neck. So we're going to talk about those a little bit more in depth, but here's just our general overview of that kind of structural positioning. We see the right side carotid coming off of that right brachiocephalic from the aortic arch. We see it traveling up that patient's neck, kind of at the level of where their neck meets their face. We're going to see that bulb, and then therefore that bifurcation where they split. Our ICA, our internal carotid artery, is going to travel up into the brain. It's going to go intracranially, and then the external carotid artery is going to stay along the outside of the skull, and it's going to supply our facial structures. So our ICA, inherently more important than our ECA. This is going to be what is supplying the majority of our brain tissues. It's in direct communication with the circle of Willis. The circle of Willis is that rotary, or that roundabout of blood supply that's literally going directly into our brain tissue. So our ICA, super, super important. Now it's going to travel from that carotid bifurcation all the way into the skull. It's going to go in through the base of our skull, and it's going to become intracranial. Once it's now inside our cranium, it's going to have two branches that come off it. The first branch is going to be the ophthalmic artery, and then the second branch is going to be the posterior communicating artery. Once those two branches come off it, it's then going to split into the MCA and the ACA, the middle cerebral artery and the anterior cerebral artery. The ICA itself, the majority of it is going to go and supply the anterior tissues of our brain. And then it's also going to have these kind of secondary supplies to our eyes, our forehead, and our nose. So that's going to be that ophthalmic artery, that first branch that came off the ICA once it entered into the cranium. That's going to be going to supply the eyes. And then that second branch, the posterior communicating artery, that's going to kind of continue the communication with our circle of Willis, and also kind of help supply our forehead and our nose. So our ICA, we need it to be low resistance because it's literally going to supply the brain, right? We don't want to impede any sort of blood flow to those brain tissues. So the vessel's going to be like, yeah, sure, like, come on in. I'm not trying to put up any resistance. Like, you get to where you need to go, and like, I don't really, like, don't go speeding, right? I need you to kind of like travel in a little bit slowly. We're going to like kind of chill out here while we're supplying the brain. Now our ECA, a little bit different. This is going to be, like we said, less important because its main responsibility is to supply our face and our facial structures. Unlike the ICA, we are going to see branching with the ECA. Typically has 8 branches: superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior auricle, superficial temporal, and maxillary. All of those branches from the ECA are going to go to supply those particular regions. So it's pretty easy to remember where those vessels are traveling. The ECA itself is going to be smaller and, like we said, less important than the ICA, and we're going to be able to follow that up into the patient's face a little bit better because it's not going to go into the cranium. It's not going to go into that patient's skull. It's not going to go into that patient's brain. It's going to stay very superficial towards the outside of their head and their face. It's going to be a high resistance blood vessel, and it's going to help us supply our face, our neck, and our scalp. So now we're moving into our posterior circulation. So we've probably heard of our vertebral arteries before. They're part of the protocol when you're performing a carotid. And typically when we see them, they're very deep on the screen, right? They're very posterior on the screen, and that's because they sit very deep in the patient's neck, hence them being part of the posterior circulation. So these are going to originate from the subclavian arteries on both sides. Our left vertebral artery is going to be a little bit wider in diameter, a little bit bigger, and that's because it's coming directly off that aortic arch. Remember, the right side, it's splitting from the right brachiocephalic with that right-sided carotid. Once they travel all the way up the patient's neck, they're going to enter at the back of the skull at this little opening called the foramen magnum. So that's where they're going to kind of join up together, and they're going to enter into that patient's cranium. So these are also going to become intracranial. They're going to unite together to form our basilar artery. So the two of them are going to meet up at the back of the skull and become one. The basilar artery is going to be a very short vessel. It's going to be 3 centimeters in length, and it's going to be kind of that back kind of completion of the circle of Willis. So it's going to be the two vertebrals that came together, going to travel for a very short distance, and then it's going to split off into the PCAs to kind of help piece together that circle of Willis. It's going to supply blood to the posterior cranial structures in the back of that patient's neck. So let's see what these look like. So here we have our vertebral arteries on the left-hand side. They're traveling behind the vertebral bodies of the C-spine, of the cervical spine, and they're joining all the way up at the back of the patient's head, entering through that foramen magnum, and they're joining together to form that basilar up in the patient's skull. Once it is the basilar, so now this picture on the right-hand side is like a further up view of what happened on the left-hand side. Once the vertebrals join to form the basilar, it's going to travel for a very short segment, going to split into our posterior cerebral arteries. And then we're going to be talking more about the circle of Willis. So how do we complete this circle? How does that anterior circulation that we just talked about with the ICA join up with this posterior circulation that we're just talking about from the vertebral to basilar to posterior cerebral arteries? So our circle of Willis, this is our intracranial communication channel. It's literally the largest collateral pathway in the body. It's an intended collateral pathway. So this is how we maintain blood flow to all parts of the brain in particular cases of stenosis or occlusion. So these vessels are very, very tiny. The vessels in our brain are very tiny. So they're very prone to plaque breaking off and lodging, right? And creating this occlusion or creating a stenosis. So we have to make sure that we can maintain blood flow to the rest of that brain if that were to happen. And that's the purpose of this circle of Willis, is that it's not just like a one-way pathway. We can get blood supply from different parts of this pathway because it's all communicating together. It's all connecting together. So the circle of Willis itself is going to be located towards the base of the brain, and it's going to have a connection between the anterior circulation and the posterior circulation. It's going to be arranged in a hexagon pattern with the distal aspect of the ICA, the anterior cerebral arteries, and the posterior cerebral arteries that are going to join together by what we call communicating arteries. The communicators are only going to be utilized if necessary. So they're only going to be utilized if we have an occlusion or a significant stenosis in a different pathway and we need to kind of bypass it and go a different route. So let's see what this quote-unquote circle looks like, this hexagon pattern. So here we have our, let's look at the picture on the right-hand side. We have our circle of Willis. This is going to be the posterior aspect of the patient's brain, anterior aspect of the patient's brain. So we said our posterior circulation is coming up from our vertebrals, joining together to form our basilar. Then we're going to have our posterior cerebral arteries right here. And then if we go towards our anterior circulation, here is going to be that distal ICA that comes up from the sides. And then we're also going to have our anterior cerebral arteries here, anterior communicating artery here, and then our posterior communicating arteries here. So we only use those if necessary, those communicating arteries. Now let's look at this diagram. So here's the front of the patient's head, here's the back. Vertebrals come up, they join our basilar. We're going to see our posterior cerebral arteries splitting from that basilar. Then our anterior circulation, we have our ICA coming in. We have our anterior cerebral arteries, which are going to supply that anterior tissue. They're going to be connected by our anterior communicating artery. And then that anterior circulation and the posterior circulation are going to be communicated with through these posterior communicating arteries on the side. Now, our middle cerebral arteries, we'll talk about these in a second. They're not technically part of the circle of Willis, but again, they can provide a necessary pathway in cases of stenosis or occlusion. So let's talk about each of these little segments individually. So we said our ACA, this stands for anterior cerebral arteries. These are going to travel medially towards the midbrain region. We kind of give these the label of A1. So anterior 1, and then we are going to see them connected with each other through that anterior communicating artery, and they're going to, and that's going to course between the two of them, the two anterior communicating artery, anterior cerebral arteries, and then they're also going to course anteriorly with each other. So if we go back here, here was our ICA. Let me just do a different color. Here was our ICA. It's coming in this way. We're going to see blood flow like this. Blood flow like this. It's going to go out into that anterior brain tissue. If necessary, the two can communicate right here. Okay. Moving into the posterior aspect, so we have our PCAs, our posterior cerebral arteries. These are going to supply the posterior hemispheres of the brain, and they are going to wrap around the cerebral peduncle. That's going to be a little extension of cerebral tissue that kind of hangs out in the back of our brain. So we had our basilar here. We said that that's going to split into our posterior cerebral arteries. These are going to go off posteriorly to supply the brain tissue out in those regions, and they can communicate with the rest of the circle of Willis using those PCOMs, or those posterior communicating arteries. The MCA, like we said, this is not technically part of the circle of Willis. This is known as the middle cerebral artery. It's kind of how like that distal ICA terminates. So the ICA is coming in this way. Boop. Same thing here, coming in that way. And it's going to be how some of that blood supply goes to the lateral aspects of the brain. So if it decides to go from, if it doesn't decide to go from the ICA into the anterior communicating artery, into the anterior cerebral arteries, it's going to continue going straight out laterally to supply those lateral tissues in that temporal region. It's going to have a bunch of branches that come off it, and it's going to end up carrying about 75% of that ICA flow. It's going to be technically larger than those ACAs because it's carrying a little bit more. So those ACAs, we're going to see a little bit less blood flow going towards them, but it's still equally as important because those are going off and supplying that whole anterior region of the brain. The MCAs are going out towards the side to supply those temporal and parietal regions of the brain. Collateral pathways, like we said, the circle of Willis itself is a collateral pathway, and we have to be able to have connections that allow all of the branches of the anterior, posterior, all of that to be able to work together. So the most common collateral pathway that we can see if there is some sort of pathology is going to be a connection between the ECA and the ICA. So even before it gets to the brain, we kind of call upon that ECA to say, hey, like you've made it up to the major leagues, like I'm going to need you to actually be important here and help supply some blood flow to the brain. And it does so by those arteries that are supplying the eye region. So some of those earlier ECA branches and that first branch off the intracranial ICA are going to join together to provide that secondary pathway. The occipital branch, like we said, of the ECA connects with the vertebral and then therefore enters up into that brain circulation. Don't worry about like that Atlantic branch. It just joins with the vertebral. So there are some symptoms that we have to be aware of, and certain symptoms come from certain regions of the brain, certain parts of that anterior versus posterior circulation. So typical terms here that we're going to hear a lot of, especially if we're doing a lot of carotids or if you're at a place that does TCDs, we're talking about transient symptoms. So the most common one that we hear of is going to be a TIA, stands for transient ischemic attack. This is something that comes and goes very quickly. Symptoms are only going to last less than 24 hours, and it's typically from an embolus from either the heart region or the carotid going up into that brain tissue. These are a little less severe than the following two. Next, we have a RIND, a reversible ischemic neurologic deficit. So this is similar to a TIA, and our symptoms resolve, but it's going to last for longer than 24 hours. They typically will make a complete recovery, but sometimes we don't know how long it will take. And then most severe, we have a VBI. This is a vertebral basilar insufficiency. We get really severe symptoms that occur bilaterally. We get really bad blurring, paresthesia. They have pretty much permanent vertigo, speech problems, and drop attacks where they can either just drop to the ground or they just lose control of their hand or their foot. Now, some more permanent conditions to be aware of. CVA is kind of the general term that we give to any type of severe permanent brain damage. So this stands for cerebrovascular accident. We can have, typically we're going to see these in acute form, but we can have these chronic because, like we said, these symptoms don't go away. This is going to be when we have sudden onset of symptoms. It's going to evolve over time, and then we could have just a complete stroke where we don't have any resolution or progression of symptoms. Causes of these, again, embolism, thrombus, or brain hemorrhage. Hemispheric symptoms, so we have to be aware of these terms. These are typically going to arise from the anterior circulation, and they have certain hemispheric relationships. So usually if you have symptoms on one side, it's because it's occurring on a particular side of your brain. So aphasia, this is going to be the inability to speak or properly express yourself. This typically is going to occur on the left hemisphere of our brain if you are a right-handed patient. So it's going to be your non-dominant hemisphere. Dysphagia is when we have impairment of speech, lack of coordination, failure to kind of get our words out properly. Again, coming from that left hemisphere, regardless of your dominant hand. Dysarthria is the imperfect articulation, a little bit more like slurred speech. This is coming from the left or the right hemisphere. And you will see that muscle control affected on the opposite side of the patient's mouth. Lateralized paresthesia, that's going to be that numbness or tingling. It's going to come from the opposite side of your, so whatever side you're experiencing symptoms on, it's going to come from the opposite side of your brain. Same thing with lateralized weakness. Hemiparesis, that's going to be from your same thing, opposite side of your brain that you're experiencing the symptoms on. Amaurosis fugax, this is something that we haven't talked about yet. This is going to be when we get this coming and going of blindness. So kind of just randomly out of nowhere, we'll get these episodes where we just can't see out of one of our eyes. That's going to occur on the same side of your brain that you're having the symptoms of. Typically going to be something going on with that distal ICA prior to it becoming intracranial. And then motor dysfunction, it's going to be on really kind of either hemisphere. So depending on what side you're having that dysfunction, you will see the opposite hemisphere affected in the brain. So there are also some particular symptoms that go with blockages in particular areas. So we usually call these, it's kind of strange, like we don't call these like particular like blockages or pathologies, we call them lesions. So this means that there's something abnormal happening in that vessel, usually some sort of plaque blockage. If we have something going on with the distal ICA, we're going to see one-sided paresis and one-sided paresthesia. We're also going to see that aphasia, amaurosis fugax, and less likely we can see myopia, which is going to be intermittent nearsightedness. MCA lesions, we can see aphasia or dysphagia, facial or arm hemiparesis, and behavioral changes. And then ACA lesions, we can see severe leg hemiparesis, incontinence, and loss of coordination. So really kind of having a whole body effect depending on where an abnormality is occurring with that cerebrovascular anatomy. And now for our posterior symptoms that can occur with those abnormalities, if we have something going on in the vertebral arteries or the basilar artery, our patient is going to have vertigo, ataxia, visual changes, paresthesia bilaterally, and those drop attacks. PCA lesions, we'll see them develop dyslexia. They could enter into a coma, and they could also have paralysis. Symptoms of general posterior circulation disease, dizziness, whirling, falling, syncope, dysarthria, severe headaches. So really particular symptoms that can be affected by particular blockages or quote unquote lesions in very precise areas. Physical exam, super important. Again, not something that we're performing, but we want to make sure that if our patient is coming to us questioning a stroke or questioning some kind of lesion, that they had a physical exam done. So palpation and auscultation are going to be big aspects of that. Palpation, we're going to be evaluating that rhythmic pulsation of that artery in sync with their heartbeat. We're going to be looking for it at the carotid, typically most likely at the carotid. And then if we can't feel it at the carotid, which we should, we could use the superficial temporal on the patient's face, the subclavian, or the axillary. Auscultation, we're listening to that. We're seeing, are there any abnormal audible noises coming from that artery in that section? We want to make sure that it sounds nice and clean, nice and pulsating. We don't want to hear any whirring, like whirling or like whooshing, because that can indicate some kind of stenosis or lesion in a particular area. Again, we're performing these extracranially, so at the carotid or subclavian. Can't really listen inside the brain, So stenosis, again, something that we are pretty much really the only thing that we're looking for when we're performing a carotid. We're looking to see if there's a narrowing. So we need to be able to identify what a stenosis looks like and how to evaluate it. We know that we're going to see really accelerated velocities in an area that's stenosed. We're going to see energy losses, especially distally to that stenosis. Our blood flow might even change direction depending on how severe it is. We're going to see turbulence. We're going to see eddy currents where we get this whirling of the color in that area. And it's going to be, just overall pretty obvious with pulse wave Doppler. And occlusion, it's going to be very important for us to identify a high-grade stenosis versus an occlusion. A high-grade stenosis is going to be really high velocities. An occlusion is going to be no velocities. So we want to make sure that we're able to tell the difference and that we're not just saying something is an occlusion when in reality we just couldn't find that really stenosed, narrow part of the vessel. So if we happen to have an ICA occlusion occurring, that means it's going to be thrombosed intra and extracranially. We can't do surgery for that patient. We can't go in and clean up that ICA. We're not going to. It's not worth the risk. What's going to happen in those scenarios is that we are going to rely on those other collateral pathways with our anterior and posterior circulation. So our ECA is going to act as a collateral for that region of the ICA, and it's going to communicate with that vertebral to be able to get that blood supply up into that brain. Now, if our carotid is occluded, we may still have normal flow in the ICA distal to the bifurcation because we're getting flow from the opposite side. So we really kind of use both sides of our cerebrovascular circulation to our benefit. So even if like your left-sided carotid was occluded and you go up to the ICA, you're like, well, how is the ICA getting any blood flow if my carotid was occluded? If it's truly occluded, that means there's nothing getting through. But how am I getting blood flow in my ICA? That's because we're getting opposite flow from the opposite side. So we're getting retrograde flow from those other vessels from the circle of Willis. So it's really, really neat to see that. And it can be really confusing because you're like, wait a minute, is it really just a high-grade stenosis? Is it really an occlusion? What's happening? With an ECA occlusion, we don't care. It doesn't do anything. It doesn't have an effect on the patient. It has so many branches that come off it that those are going to act as collaterals within themselves. So again, we don't really care if there's an occlusion, but the main thing to take away from this is that if there is an occlusion, if it is completely blocked, we do not go in and surgically clean out that vessel because we rely on the collateral pathways to provide circulation. We do go in surgically for high-grade stenosis because of the really high velocities traveling through it. We don't want those super fast velocities having an impact on that cerebral tissue in the brain, and we don't want those high velocities to break off a piece of plaque and have that embolize somewhere else in the brain. In occlusion, we don't run that risk, right? Because there's no blood flow, so we don't have to worry about those high velocities. Cerebral thrombosis, so we said this is going to be when we have a thrombus formed within a brain-feeding artery. It's going to create a blockage in that distal tissue, and it's going to starve off those brain cells of oxygen. So we want to rely on that circle of Willis to help us in any case possible. A cerebral embolism is when that thrombus actually moves somewhere else. It's going to typically travel more distally through those cerebrovascular arteries up in the brain. Again, it's going to starve those brain cells from oxygen. We're going to see an irregular heartbeat. This is really common in patients who have already had a heart attack before or have a history of embolism elsewhere in the body. So we want to be aware of that patient history. It's nice that we have a circle of Willis that can provide a collateral pathway, but we don't want to have these things anyway, right? We don't want to have to rely on those collateral pathways, especially if you're only 40, 50, 60 years old, and you're relying on a collateral pathway in your brain to keep you alive for the next 40, 50 years. So it's, we don't want to have these things, even though we have a backup plan if necessary. And additional conditions that we have to be aware of, again, the cerebrovascular circulation is still going to be prone to atherosclerotic plaque, aneurysms, dissections. We also see an impact from fibromuscular dysplasia in the brain. So it's a condition that's going to cause stenosis and aneurysms of the vessels. So we're going to get this bead-like appearance. We're going to get these areas that are really narrow, followed up by areas that are really wide, then narrow, then wide, then narrow, then wide. Very common in young women, and we see this in the carotid and renal arteries of those patients. We also can see carotid body tumors. These are going to be tumors that are super vascular that can develop right in between the ICA and ECA bifurcation. So right at the bulb in that patient's distal neck, we can kind of see like this little soft tissue tumor that has like a ton of vascularity to it, sitting right between the two. It's not a lymph node, it's a carotid body tumor, and we should remove those because it's taking away blood supply from the rest of the circulation. Subclavian steal, this is a really interesting phenomenon, and it is when we get a stenosis in the subclavian artery proximal to where the vertebral artery is going to come off it. So that vertebral artery is going to be saying, hey, I'm not getting blood supply from this subclavian, what's going on? And what's going on is a blockage. So what it does is it steals blood from the vertebral artery itself, and the vertebral artery kind of works backwards to supply the arm, right? Because our subclavian goes off to supply the arm, but it also supplies the vertebral. So it's almost like the body's like, oh, well, I need to supply my arm, but it forgets that it has to supply the brain too from that vertebral. So it kind of just has this effect where it pulls the blood down from the vertebral to bring it down to that arm, but then that vertebral doesn't have blood supply, so it's got to steal it from the other side vertebral. So it's going to result in insufficiency, those VBIs that we talked about, and neurological symptoms. So although it's not a technical blockage in the cerebrovascular circulation, that blockage in the subclavian artery has a really big effect on it. So here's kind of just that overall diagram of what that subclavian steal is going to do. It's literally stealing it from the other side. So say in this example, our left subclavian is blocked prior to where that vertebral artery would be being supplied. So if you look back at the left side, you have, the right side, we have our brachiocephalic, we have our right-sided subclavian here, our right-sided vertebral here. It's going up as it should, and then it's going to get to that junction where it should join with the other vertebral and form the basilar, but it's saying once it gets there, it's like, whoa, this needs my blood supply. So I'm going to come down and I'm going to go off into that left-sided subclavian to supply that left arm. So a lot of new information on here. Hopefully you've had some exposure to this in clinic. Our next PowerPoint, we're going to be talking about the exam itself. So we'll come back to stenosis, velocities, all that good stuff when we move right into the next one.